Continuation, peripheral artery disease. Today, carotid artery stenosis. Let me get my red thing. Hold on. Red pointer for artery disease. I probably should have used, I want to apologize. The peripheral artery disease, the audio is kind of weird, so hopefully we have better audio this time. We figured it out. I was listening to Pandora while I was doing charts. It didn't work out like it was supposed to. Anyway, peripheral artery disease, same subject, but now we're getting into what happens when you don't scenarios. Risk factors, still the same. What is it? Narrowing of the blockage of a carotid artery due to a plaque formation resulting in tissue ischemia. You basically form tissue inside an artery and it's not supposed to be there. As it narrows, you can start to develop symptoms. The magic number is 50%. Now, there are some numbers that we'll talk about when we start addressing treatment that kind of make some changes as far as what do you do, medicine versus surgery. But for the most part, remember 50%. If it's greater than 50%, there's a good chance you're going to need surgery because you will start having symptoms. Signs and symptoms. A carotid bruit is what every medical student on the planet wants to be able to hear. It is basically a shoo, 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 shoo when you listen to someone's carotid artery. You see it and hear it really well on ultrasound, and I'll see if I have a Doppler recording of it. I'll see if I can find something. I'm sure I can. But that's what everybody wants to hear. So that's why they're putting their stethoscope right over your neck, right here, usually above or around the sternocleidomastoid, which is that big muscle that connects from your chest all the way up to your ear. Now, once you have a carotid bruit and you are in the realm of carotid artery disease, there are only two ways that this presents. Either you have a cardiologist that is doing or a primary doctor that is doing excellent screening, or you have vague symptoms that don't make any sense and we check your carotids by accident and we find stuff. Vague symptoms can be dizziness, headaches, can be shade going over your eyes, like shade coming down over your eyes. It could be any type of neurological symptom that someone doesn't understand. The first place we usually start is with a carotid artery check. Now, ischemic symptoms, partial or complete blindness, absent pupillary light response, hemiparesis. So one side goes down, you can't move it. The other side, you can't sense anything on the other side. You're ignoring that side. Dizziness, confusion, loss of coordination, slurred speech. All of these symptoms go into the TIA, transient ischemic attack grouping. This is different than a stroke because you can get these and they resolve. If you get this stuff and it resolves, it is a TIA. If you get this and it doesn't completely resolve, you have had a stroke. A TIA, transient ischemic attack, is your first sign that you have carotid disease, and when you have it, you need to take it serious. Listen to me. You need to take it serious. You need to go get checked out, and you need to have someone do significant tests to make sure that you have it or you don't. Because if you do have it and it's from carotid artery disease, you can get it fixed. You get it fixed soon, you don't have a stroke. Carotid arteries are usually 1/3 the reason that people have strokes. The other is usually intracranial stuff. So you need to make sure that if you think you had my arm went weak but it got better, or kind of was talking weird and it got better, go see your cardiologist, go see your primary doctor. If your last name is Crawford, let's see your general surgeon that you have in the family or whatever, vascular surgeon. But you need to see somebody to take that seriously. That is a difference from you being confined to a wheelchair, having a stroke, and not being able to feed yourself for the rest of your life versus having it diagnosed, getting surgery, getting fixed, and moving forward. Sorry about that. Now, anyway, atypical symptoms, unilateral limb shaking, transient loss of monocular vision, amaurosis, fugo, that's on every test you have. That's a sign of a carotid artery disease. But it also can present asymptomatically, just, oh, dizziness, oh, I didn't feel right, lightheaded, whatever. Again, this is your opportunity. These signs and symptoms are your opportunity to get fixed quick. To understand what we do about diagnosis and treatment, you kind of have to have a quick summary of the artery. This why is the issue, is the why. The why is the why. That's pretty cool. I have to remember that. You have the internal carotid artery that goes to your brain, and the external carotid artery that goes to your face. You will have a little bit of blockage in the external carotid artery, but it's not really an issue because your face has such good blood supply, and unless you're doing a lecture on YouTube, you don't ever get face claudication, so it's not a real thing. The way that we tell the difference between the external and the internal, this is a question I always ask the medical students, is there's a branch that comes off of the external carotid artery. It's called the superior thyroid artery. It actually is the first branch after the common, and it goes to your thyroid. So that's how we know which one's which. What we do in this procedure is open it up, pull the plaque out, and close it up. If you close it up smaller than it is, you've kind of limited the blood flow. So the majority of the time we do what's called a patch angioplasty. We'll talk about that. But that basically closes the hole so that it's not smaller by putting a patch over it. The tricky part about this operation is it goes from the aorta, common, straight up to your brain. So you have a circle of Willis. I'll show that little picture. It's a great one. That gets blood supply from the other side, but you either shunt or don't shunt this. And shunting continues blood flow to your brain, especially if a blockage on the other side. Not shunting assumes that your circle of Willis is patent. But before we get to talking about surgery, we first have to make sure how to diagnose, or have to figure out how to diagnose this blockage. The first screening test is a carotid Doppler. A carotid Doppler does a couple of things. It's nice because it looks at flow, so we can look at the velocity of the blood flow going by relative to the size of the artery. It is a computer calculation. Computer will tell you the stenosis is probably greater than 50%, greater than 70%. They can also see plaque in the common carotid artery sometimes, which also gives you a suggestion of carotid stenosis. The reason it's a suggestion is because you have to have two tests to determine whether or not someone needs surgery. The gold standard is an angiogram or cath. So they basically put a cath in your groin or your arm, go up to your carotid artery, shoot dye in your carotid artery, and look at the stenosis and see if it's 70, 80, 90%. If it's not, if it's less than 50%, you don't need surgery. If it's 50% with an ulcerated plaque and you have symptoms, or 50% and you have symptoms, you need surgery. If there are no symptoms, so this is picked up on a screening, you get kind of tricky in those numbers, and realistically, a good number is 80%. 80% without symptoms, you need surgery because you have a significant risk of developing a stroke. Some of the literature says that is as high as 22% to 25%. When you do surgery, you can drop that down to 9 to 11%. So it's a significant reduction. If you can't do an angiogram for whatever reason, or they don't want to do an angiogram, you can do a CTA of the neck or an MRA of the neck. Those are the next best tests to be able to tell us, yes, I have significant stenosis in that artery. With those two tests, one to screen and another to diagnose and for surgical planning, you then can proceed with a carotid endarterectomy, abbreviated CEA. CEA is the gold standard of carotid revascularization. The first time we did this surgery, Dr. Michael DeBakey, he's credited with doing it. He basically went in, took the carotid out, and put a graft in. From there, we went into opening the artery. So we would go in, clean it out, open the artery, and then close it back up. We found that closing back up makes it a little smaller, so now we're into the patch angioplasty phase of this operation. Probably around 2003 to 2007 or 8, they were looking at doing stents in the carotid. So sometimes in the past, people were getting stents. What we found out was, after all the trials, is that a stent is really not a good idea in the carotid except for under 2 situations. Part of that has to do with what we're dealing with. I'll show you some plaques that we pulled out of carotid arteries, and you'll see this stuff is hard like rocks. So it's not just going in, putting a stent in. Once you do that, you will shower pieces of this into the brain. So a lot of these systems that they use to put stents in had baskets that would catch the stuff while you're putting the stent in so that you didn't cause a stroke. Even in that situation, it was really operator dependent. It just didn't work that well. So now stents are used for 2 primary reasons. The first reason is if you have anatomy that does not allow surgery. What that means is somebody's carotid artery bifurcation is so high underneath the jaw that you have to dislocate it or transect it or do something like that. In those patients, they typically do better with a stent. The second indication is a redo. So if I do your carotid, you continue to smoke, you continue to not control your diabetes, continue to eat a lot of fat burgers. I like a fat burger, that's why I always pick on fat burgers. But you eat a lot of high cholesterol foods, you will end up with a restenosis. Or if I do it wrong, you can get a restenosis. In those situations, a stent works because the restenosis is actually smooth. It's not rough, so you don't have those same little pieces of calcium in there that can embolize to the brain. So redo carotids, we typically stent those. People that we can't get to the carotid because of the anatomy, they also require stents. You also have to do lifestyle modification because you don't want to end up one of these patients that restenoses a carotid after we've done an endarterectomy. Again, statins, hypertensives, because these put you at significant risk for peripheral artery disease in general. Antiplatelet therapy. Antiplatelet therapy is pretty interesting in carotid stenosis. With a carotid artery, traditionally you need to be on a full dose aspirin, not a baby aspirin. So as soon as you have carotid artery disease, even at 50%, you should be up from baby aspirin to full dose. If you have other arterial disease sequelae, so bronchoedema, heart disease, chest pain, angina, they may put you on Plavix instead. When we do carotid artery surgery, we originally did not do patients on Plavix. We always held it or some type of antiplatelet therapy. What we've now learned is that patients that have carotid artery, whether you're on some antiplatelet agent versus not, there's a 50% reduction in the likelihood of you having a stroke during the procedure. If you're not operating on someone that has a transient ischemic attack recently, or someone who has a history of strokes, and it's just a regular person off the street, you find an 80% stenosis, there's about a 4% to 5% chance of them having a stroke during the surgery. Now, that's way better than 25% if they don't. If you put them on antiplatelet therapy, whether it's Plavix or full dose aspirin, you reduce that down to 2.5%, so 50% reduction. The downside is you will have some wound complications. So you can have a little bleeding into the incision, so the incision can get hard. It softens up over time. It's not a big deal, but when you compare a very good looking incision right after surgery versus possibly having a stroke, all patients say, okay, I'll deal with the funky looking wound for a little bit, but it eventually softens up. So antiplatelet therapy should not be stopped during your carotid surgery. If you're on something like Xarelto or Eliquis, I typically back you down and put you on Plavix for the procedure, and then 5 to 7 days after the procedure is completed, then we can restart you back on your medication. As far as complications, there's a chance, like we said, of a stroke or a TIA during the procedure. If you have a TIA and you wait to get your surgery, you can progress to a stroke. So depending on your surgeon, some surgeons will do TIAs immediately. Some people will wait 2 to 3 weeks to do them. But if you have a stroke and we have to do your carotid, we have to wait 4 to 6 weeks so you don't get a reperfusion injury and worsen the stroke. But in that meantime, waiting, you can develop one of these, or after the surgery, you can develop one of these. One of the worst strokes I've ever had after a carotid artery was a gentleman that had a hypercoagulable state that he didn't know, we didn't know, no one knew, but after the fact, the way that he presented with his stroke immediately after surgery, we started doing some family investigating, and we essentially believed that they had some hypercoagulable state. Any person that has peripheral vascular disease and has peripheral vascular surgery is at risk for a heart attack right after the procedure. The main reason we keep peripheral artery patients in the hospital for 8 to 24 hours, surgery we do 24 hours, stents they sometimes do 8 hours, maybe a little less depending on how severe the disease is. The biggest thing that gets us is always a heart attack. So we're watching you for 24 hours in the ICU, one, to watch for a heart attack. The other thing that can happen is you can have a stroke from me increasing the blood flow to your brain. If your blood pressure is high before the surgery, it can be because your heart is trying to increase the blood flow to your brain through a smaller hole. So there's limitations. When I open that back up, you have a lot of blood going to your brain. Your brain says, hey, we need to decrease the blood pressure. So it actually can drop the pressure so low that you can have a stroke, or you can actually have ischemia to intestines and stuff like that. So we have to artificially elevate your blood pressure sometimes right after carotid surgery, just so your brain can equilibrate and say, okay, this is my new set point and I'm okay. So that's one of the things, that's the other reason that we watch you in the ICU for the first 24 hours after surgery. Also during this procedure, we're doing a lot of retracting, especially if your bifurcation is underneath your jaw. You can get injury to some of the cranial nerves. You can get some limited facial paralysis because of retraction on the facial nerves. But that usually, again, is transient. After about 6 weeks, that goes away. The difference between knowing whether that is a stroke versus a retraction injury it's pretty simple. If I'm operating on the left and the paralysis is on the left, it is more than likely from a traction injury. But if I'm operating on the left and it's on the right, then you have to consider that it's from a stroke. The last complication that we all have to deal with sometimes, especially if you're doing it correctly and you're on antiplatelet therapy when you do the procedure, is a hematoma. You'll have hematomas from time to time. It happens. They will resolve. The one thing you want to make sure is you don't have a patch that is blown apart, or you have a pseudoaneurysm that forms from bleeding coming out one of the suture holes. So after we put the patch in, we can watch it. We'll put fibrin glue over it. We'll sometimes put Surgisil over it, whatever we need to do to make sure the bleeding stops before we close. But sometimes there's a little oozing because you're on antiplatelet therapy, and we don't want you to have a stroke. That's it. Carotid artery disease. So now we've got the head. We'll start going down, looking at what happens when you have bad toes, when you have to lose a leg or part of your leg or something like that. The most important thing from this talk is to remember, if you or a family member have any of these risk factors and they are dizzy, funny speech, change in mentition, which means mentally they're not right, or have an issue, make sure that they go get checked out by their doctor, because this may be that grace period that we can see them, figure out what's going on with them, put them on antiplatelet therapy, and then get them operated on, get them taken care of, and go from there. One other thing that I did forget, sort of, but not really, is 50% stenosis with symptoms, you need surgery. 80% without, you need surgery, 70 grace period. Remember that when you're talking to your surgeon and they talk about the stenosis that you have, then your surgeon, he or she, can get you taken care of, versus saying if you're less than 60%, you can just do medicine. If you haven't had any symptoms, we can repeat your ultrasound in 6 months. Hope that answers everything. Now we'll start talking about cutting off toes. Remember, call me, DM me, don't call me, but send me a message, email me, something like that if you have questions. All right, guys, thanks.
Ain't nothing wrong with thunder with the rain.